Welcome, everyone. My name's Dr. Lani Roy, and I'm the coordinator of the Mental Health Professional Network. It's the first psychedelic and plant medicine network that we formed in Australia, and we've come a long way, given initially it was a no. They, weren't ready. And now, the Department of Health and the network being fully supportive of education and training for practitioners all around Australia. So very excited today to have Dr. Lynne Morski talking with us about how to bridge the gap, incorporating psychedelics into the current medical model. And I think what we'll do today, if I'm right, Lynne, we'll have a couple of, if you've got some slides to talk through. And I guess what we're really looking at here today is the Australian system, but also what Lynne has experienced and experiencing as a leader in this space, and really kind of exploring the complexities and what we need to do to change and stabilize these medicines into our system, into our healthcare system. So yeah, and before we begin, I'll just briefly share a little bit more about my work, and then we'll do an acknowledgement to country just to ground in together. So yeah, many of you might know me from the Science of Life Psychology, which is a national integration and psychotherapy service, as well as student placements. We also do a lot of trial protocol development and consultation. But I'm also very excited to say I'm a founding board member of AMAP, and AMAP is the Australian Multidisciplinary Association for Psychedelic Practitioners. We just had our launch, our conference on the weekend, hence why I'm exhausted. Yesterday I was just floored what it takes to, and as Lynne would know, to start something new from the ground up, from every policy, procedure, putting a board together, takes enormous energy. And so very excited to be part of that team. And I encourage you all to have a look at that website, because we have set out a credentialing pathway for preliminary psychedelic therapists, fully accredited supervisors. This is a roadmap to credential practitioners in Australia, with a lot of checks and balances and safety nets and accountability. So yeah, I really hope you can reach out and learn about that. And we'll ground now into an acknowledgement. So if you'd like to, you can close your eyes if you feel like it. Just taking a moment to acknowledge the traditional owners of all the lands in which we come from in Australia and around the world today. I'm just tuning into somewhere in Australia or in your country that is a great resource for you. Might be the bush, a water body, a river, beach, waterfall, the desert. Just knowing we have access to these incredible elements in our country, and the wisdom keepers that hold incredible access to allies, wisdom traditions, being custodians of these lands. And yeah, beautiful acknowledgement to all the medicine holders from around the world who have worked in sacred ceremony, in the teepee, in the Maloka. Now it's moving all around the world to our labs, to our backyards, to our organisations, and may we really learn how to integrate science and the sacred in our medical systems. Thank you. Beautiful. And Lynne, I will make you co-host so you can put your slides up. Just one sec. There you go.
Hi.
I'm recording your end.
There.
Beautiful.
Okay, sorry. It was like as it was turning from one to the other, I went to hit it and it hit the wrong thing.
Okay.
Sorry, guys. Hi, I'm Lynne Marie from the US. If the accent wasn't the first indication, I could be Canadian, I guess. Thank you very much, Lani, for having me tonight and for everybody who has shown up. I have this big slide presentation. We will not go through most of it. I'm just going to kind of hit on the highlights because I would love to have a kind of interactive discussion. I do not know the Australian system. You guys are further along than we are by a lot, in that you have any legal way to do psilocybin and MDMA. So we cannot wait to learn from you all. But I think a lot of the things that I'm going to be discussing about how the medicines fit into the traditional system are probably pretty similar. Forgive me that I do not know whether you all have the system where you have to go to a primary care person and then they refer to a specialist. Is that like, that may come up at some point. If somebody could put in the chat whether or not that's how your system works, great. But let me go ahead and get to our slides. The reason I'm asking that is because it's relevant to our chit chat. So, okay. Here we go. Okay. How much of my screen is covered up by the little chat, the little faces of Zoom?
Perfect. That's perfect.
None? Okay, great. On my end it is. Okay. So in case anybody wants to know, because a lot of people ask, like, how did you get into psychedelics? I went to med school, then I did a residency in family medicine. Then I did a sports medicine fellowship, which is not relevant at all. And then I worked at the VA for 9 years. So that is, as you probably know, the Veterans Administration is where veterans go for care after they've left the service. Somewhere in there, I went to law school. That's my law school graduation. And somewhere in between all of that, I realized that psychedelic medicine was a thing that was very effective, that I was not allowed to tell veterans about while I was working at the VA because I was a government employee. And so in 2019, I left medicine and made it my mission to spread the word of psychedelics to clinicians primarily, because we listen to each other, right? We speak the same language. And so then I started the Psychedelic Medicine Podcast thinking that was the way I was going to educate clinicians, but we don't have 45 minutes to listen to a podcast. So I then started the Psychedelic Medicine Association, which our mission is to educate clinicians around the world, it's global, on psychedelic medicines, because we want clinicians to be able to discuss psychedelics with their patients when there's a psychedelic option that's appropriate. We want them to be able to do a clearance when that's a thing they can do. We want them to be able to make a referral. So, we've really focused, our main focus is on the primary care physicians, because at least in the US, that's who makes the referrals. And that is who in the US is writing 80% of antidepressant prescriptions. And so if doctors don't know that there is a better option, once there are better options, and we already have ketamine, which is a better option a lot of times, then they're going to keep writing the prescriptions for the things that are not as effective. So that's our mission, is to educate clinicians and therapists. And so I'm not just saying doctors. If you go to your therapist, we want that therapist to know, hey, psychedelic assisted therapy is an option. Maybe I refer you to them if, whatever we're doing could be augmented in that way. Nurses, PAs, acupuncturists, anybody who sees a patient, who has a license to see a patient, we are there to educate you. So that is what the Psychedelic Medicine Association is. Now, as you probably know, I didn't have a chance to gauge your knowledge of medicine, but this all looks different for you all. MDMA and psilocybin totally going to be able to be prescribed. Lucky you all, amazing. Just so you know, most of this is going to be discussion about things that we need to consider. I don't necessarily have a lot of solutions, because this is, a giant work in progress in all of the countries, right? I think you all know very well what this looks like to be in action of figuring out a thing. Oh, the law has changed. How do we figure out how to make that work? So first off, the challenges. And here are the big four. Now, just imagine your patient. Let's say your patient, very basic, has, we're going to say PTSD for the thing that for us will be, you guys have MDMA nowish, we'll have it hopefully soonish. So a patient has PTSD. What stands between that patient, as they currently are, and that patient getting something like MDMA-assisted psychotherapy for PTSD? Number one, the provider knowing about psychedelics and accepting psychedelics as a reasonable, efficacious thing they would refer to. Now, even if you go to a doctor who does know that, the second challenge is patient knowledge and acceptance, because imagine you say, I think maybe MDMA assisted psychotherapy, and all they know is, oh, MDMA is Molly, that's a club drug. And then they don't know enough about its therapeutic benefits, and they don't accept it, war on drugs and all that, for them to feel comfortable taking it. Third huge challenge is availability. First off, we have to get it legal. And then we have to get there to be enough trained providers or retreats or clinics that are offering this so that it is widely available. And then fourth challenge is affordability. There's another challenge that should be on there, which is like the logistics of working it, but we'll get to that. The fourth basic challenge is affordability. You know, they have done studies showing MDMA assisted psychotherapy is going to be cost effective, but that's over the long term. It still costs something like $10,000 up front, or it can. And so how does somebody come up with that, or who covers that up front so that they can actually afford to have this? So going back to the four things: provider knowledge. Where do providers learn about things? You know, school, residency, continuing ed. We already have some things that are appearing in journals. We're getting some psychedelic continuing education. The Psychedelic Medicine Association just made a course. Provider knowledge. There has been a study done, I think it's about 2 years ago. About half of clinicians have already had patients ask, and about half also say they're not very knowledgeable about it. Luckily, 87% were interested in learning more. The 13%, we're not sure what they're doing in medicine. Just something I always love to add in here. This crowd does not need to be told this, but I always say, like, the majority of doctors are not being willfully ignorant. They were just never taught about psychedelics. So if you go into your doctor and your doctor doesn't first line tell you about psychedelics, they probably just don't know. Now, how do we overcome this stigma? In the US, we had, just say no, and we've all had all this prohibition. So we have to work on not only getting providers to know about these, but getting them to accept them. Now, like I said, on the patient side, how do patients learn about things? Well, they learn about it. Look at this drug advertisement, right? That's usually they see these advertisements. Luckily, they also see media, and we're getting some more, we're getting a lot more media coverage than we ever have been. But they have to overcome the stigma as well. What if I have a bad trip? It could be really scary. I could, drop out, all the things that they know from the, the 60s or the counterculture or whatever, the just say no, people said, drugs will melt my brain, right? We've got to get over that. In addition to the provider getting over their stigma so that we can get the patient the medicine. Now, this is a totally US slide, so we will skip that. Affordability. The way that we have it now is, we need to get things covered by insurance. Very interested to see how you all are doing that in Australia. Right now, a lot of the heavy lifting is being done by nonprofits, like especially for the veterans. And, we hope that it's at some point in time, we have some state sponsored coverage as well. So some of the solutions, and these are very quick, and then we'll get into some very specifics, but things that you all can do to help in these areas. So if you happen to be in academia and you have any access to the curriculum committee, would you please put a little bug in their ear? Like, hey, psychedelic medicine is coming. Our students are going to need to know. Maybe we should start having a course, or at least get them into the Psychedelic Medicine Association, which is free for students. Any way that you can get the students to start hearing about these. So we, the more you hear, the less the stigma, the more the knowledge. Also, do you happen to run a student group, or, could you suggest to one of your students who might have an interest in this to start a student group that discusses psychedelic medicine? Now, here's a big one. Once we get to training, like residencies and fellowships and clinical rotation, if you're looking to, if you run one of these, or if you are advising students that may be going into one of these, think about psych residencies. They should have ketamine assisted therapy as a discussion. Definitely, because that's legal. Definitely, at least in Australia, other psychedelics should be discussed, the ones that are now approved. But they should also have things like the ability to get to rotate with psychedelic assisted therapists. And also, perhaps they could be getting credit if they do take a psychedelic assisted psychotherapy training program. Why would they not want to come out of their residency with an extra tool in their toolkit? And they should be getting credit for that, I think, in their residency. And then also, if you're one of the faculty in one of these programs, consider doing a journal club on a psychedelic research article. Providers. So like I said, we're hoping to get things about psychedelic medicine into the major CME hubs that we use, like free CME. That'd be great. Ways that you can help with provider knowledge in your own world is if you do have a journal club in some way, or your friends get together, or you have a subgroup, like, Lani, who's kind enough to invite me here. share the topic with your colleagues and in your professional groups. Drug reps will be coming, pharmaceutical reps for psychedelics will be coming, and that will help with provider knowledge. And then associations. There's the Psychedelic Medicine Association. That's ours. I know, Lani has just founded her, yours. I think the address is in the chat here. And this helps you learn about psychedelics and also network with other people, discuss different, methods. Who do you refer to? What clinics do you like? Or if you're interested in getting into practicing yourself, which training programs have you taken? What did you think about them? That kind of thing. Overcoming the stigma. Well, at least what I've seen in my 3 years of running, the Psychedelic Medicine Association turns 3 tomorrow, it's already tomorrow in Australia, so happy birthday us. We overcome the stigma in those past 3 years. Whenever I talk to, some stalwarts that seem like with their heels dug in, we have to combine evidence-based medicine with anecdotes. That seems to be what's the most effective. Now, for evidence-based medicine, we need evidence. So thank goodness trials continue. So we need more research. But once you combine that evidence with anecdotal stories, like you see here from Marcus Capone, you may have seen him before. He's the founder of Vets Inc. All over the US. He's been trying to get laws changed. And I think that's kind of the 1-2 punch that like gets people to yes, you can see data, but like once that data has a story behind it, I think it's even more powerful. Patients get their information from us. So if we can get discussion started, that's really important. And to get patient acceptance, we just need more balanced media. That's a great start. And the more that we are okay with it, the more they are likely to accept it, because a lot of them still come to us for their, with their, here, best, you went to such and such training. What do you think, right? If we think it's okay, we give them the knowledge that we believe in it, we believe the evidence, then hopefully they will help. That will help them do the same. Availability, all these things, we can, let's get to the logistics. Okay. These are some of my favorite questions. This is where we have fewer solutions. But when it comes to something like Australia, I'm assuming you have ketamine already. Correct me if I'm wrong. And again, if you correct me, I won't see it because somehow my chat is not showing up on top of this thing. But let's say you have ketamine, and then you're also going to have, psilocybin and MDMA. How do we decide which therapy is right for which patient? I mean, we're finding out, if you look at the body of research, so many psychedelics are good for so many things. So right now, yes, we know psilocybin is really being looked at for depression and MDMA really for PTSD, but there's probably going to be a lot of crossover. Johns Hopkins is, if they haven't already, they were going to publish a study that showed how much crossover there was in what medicines were helping for what conditions. So who selects the therapy? Is the person referring the patient, maybe the primary care doctor? Or do they go from primary care to like a psychedelic specialist and that person decides? Or do you send them to one and hope that's the right one? Like, this is a big question, is when there's more than one therapy that could be appropriate for a patient, who selects that therapy? Who makes the decision of where to send the patient? The next thing that needs to be addressed is who does a clearance, right? Of the two that you all have, newly acquired the ability to refer to, psilocybin, fewer reactions, MDMA, a little bit more. But if you're a primary care provider, do you know all the indications and contraindications for those? Most of us don't. And so it requires specific training. Who needs to get that training? Is it the primary care person again, or is it the psychiatrist, or is it the person, like, the actual person who's prescribing the medicine? Because at least the way it works in the United States, if I am an orthopedic surgeon and I have a patient who needs a surgery, I send them to anesthesia, and anesthesia does the clearance, because as an orthopedist, I'm just supposed to know how to hammer the bones in place. I don't need to know how the heart's supposed to look to survive anesthesia. That's anesthesia's job. In psychedelic is basically spiritual surgery, and we need a clearance. Who does that? Especially something like ibogaine that really can have cardiac consequences if the patient is not properly cleared. We need to know who's doing the clearance. Who does preparation? Is it the facilitator? Is there a separate preparation coach? Is it the patient's therapist that they've been seeing for like regular stuff, and then like now suddenly they change to focus on the psychedelic preparation part? And then who does integration? Again, the same few people could be. It could be the facilitator. It could be a separate integration coach. It could be their therapist. It could be their psychiatrist, but who's actually trained to do that, right? And who do, a lot of people say, oh, I went to ketamine and I went back to my therapist. If the therapist understands altered states of consciousness, great. If they have no paradigm whatsoever for understanding that, and you start talking about the things you saw, imagine they might think like, oh, did you have a psychotic break, right? Like you need to be going to somebody who knows integration, who understands working with somebody who has experienced these altered states of consciousness. Oh, I've already gone through all this. By the way, in the US, there are 3 universities are coming together to form a new medical specialty. It's a fellowship, psychedelic medicine fellowship for psychiatrists. Still, since it's a fellowship of psychiatry, they're not usually the ones we ask to do like cardiac things, right? They're usually doing head up stuff. So unsure if that's who's going to be doing it for us. So this is the end of my like formal slides. By the way, I will at some point put a little link to join the Psychedelic Medicine Association if you'd like to. Don't tell the higher ups, but I got a massive discount, so it's only like $100 for this. I just stole a little link we use for something else because I would love to have you all join. I'm going to put that in the chat, but I would love to now close this and go and see your comments. Hopefully, we can have a discussion. One sec. Okay.
You're a powerhouse. I can feel your passion and power behind your words and what it takes systemically to change the system. So I guess this is the time for anyone to ask any questions about, we're focusing on the Australian context, and then I can give speak to that as well. And then Lynne Marie can jump in with her perspective too. So you can pop your hand up, or write it in the chat. You can ask anything about where we're up to with different medicines, the TGA, AMAP, any questions at all. Don't be shy, it's going to be a long half an hour.
Hi, Lani. Can I start? My name is Nelly Brazis. I'm counselor. I've been I did CPAT, and I was wondering if you can update us on the status of. Okay, so from the 1st of July, the psychiatrists are able to prescribe the medicine. How many psychiatrists actually do you know of who have been in a position to prescribe, so got a permission, and they I assume they will have the team ready, like the therapist, clinical psychologist, the psychotherapist, and they will probably need to have some space to do this. So do you know how is this happening in Australia right now? Is there like an example of that already?
Yeah, and I think that's really good to educate clients that this is actually going to be a very slow process. Okay. Because I think there's been so much hype that a lot of clients thought, from July 1st that it's just going to happen. The reality is I only know of 2 authorized prescribers that have been given that license. One's taken off to another country for a holiday and the others have submitted, they're just at the space where soon they should be allowed to go forward with their first patients. But it's, a very tricky process in the sense the prescriber has to get authorized, and they have to put in a application to a HREC, so get the protocol approved. At the moment, there's a little bit of complexity. Some HRECs have been refusing to allow anyone but a clinical psychologist to be in the room. So obviously at AMAP we formed, because we're very passionate about multidisciplinary triad, so psychiatrist, prescriber, maybe with a GP and a psychotherapist, or a psychologist and a psychotherapist with a medical professional in the facility. So looking at all the logistics around making sure that it's multidisciplinary, it represents our clients' needs, having an Indigenous therapists, most Indigenous people don't get PhDs and APRA accredited credentials because of accessibility issues. So to not allow them to be in the room would, is a real human rights issue. So yeah, so there's a little bit of complexity at the moment that we're advocating with AMAP, because the TGA has said that they would like it to be a clinical psychologist or equivalent. But from my interpretation of the TGA is that they prescribe and approve of the substances. So it's not actually their remit to talk about the therapists. So there's a bit of, we're just trying to figure out, are people overstepping boundaries here? Are people aware that that's not actually best practice that's happening around the world? MAPS doesn't just work with clinical psychologists. So yeah, I don't know anyone who's actually under the new laws administered the medication just yet. They're slowly getting there. But then it's of course the cost, and it's, estimated at, unless it's done through Veterans Affairs or NDIS components or some, type of philanthropic donation, if it's just cold cost, it's about $25,000 for 2 doses. So again, that's something that clients need to be aware of when they're contacting is the cheapest and most accessible medicines at the moment are cannabis and ketamine. And then, MDMA and psilocybin, unless you've got insurance or pathways, it's going to be really quite expensive.
Okay. Thank you for that. Thank you.
Sam's asked a question there. Lynne, are you able to talk a little more about the upcoming psychedelic medicine training in the US?
I wish I were. When they announced it, it was in like 1 or 2 articles with no specifics. So when I wrote to them, all I got was that it would be a fellowship after psychiatry. So, and it's a few years down the road. So I wish I knew more. I wish I knew like what it would cover. I'm not sure that they, had that all ironed out at that point, unfortunately. Sorry.
Yeah, thanks, Lynne. Yeah. I mean, in Australia, your psychiatry training will be 5 years, and the last 2 you can do advanced training and advanced traineeship in a subspecialty. Do you think it's that sort of thing that I'm not sure how similar it is in the US, or is it something that will just come, once one's full psychiatrist?
It's going to be, I think, a fellowship. So in the US, you do a residency, and if you graduate from a residency, you can do a fellowship if your specialty is allowed. And so like I asked what residency would be allowed in that fellowship, and they said psychiatry. So yeah, it's one of the, like, it's not a one and done. Like this should be like an existing fellowship that every year takes, a few fellows. Unfortunately, a few is not going to cover the country. So hopefully like once we have one, hopefully others will follow suit.
Interesting. Thanks.
And Shana just asked there, I put in the AMAP website where policies and procedures are like a credentialing roadmap. So anyone that's wanting to see where their qualifications fits in, you can see what you would need to do, to be credentialed, the pathway forward for that. And welcome any feedback as well. We've had a lot of minds working on it and pulled it together. But if you see that there's something missing or someone in the community that should be doing this work and isn't in the policies, please let us know. But we think we've kind of captured the reality of the medicine kind of field to the best of our ability. Any other questions? I guess I'm curious what it's like for all of you in your practices these days. Are you still facing a lot of stigma, a lot of people not knowing about these medicines? Any roadblocks from where you're positioned?
I'm happy to address some of the questions that came up in the chat.
That's right.
So first we have, as the drugs are very expensive, would there be the possibility of people self-medicating from illegal sources? I don't want to speak for Australia, but that's what most of America has been doing for a very long time. Unfortunately, and I only say unfortunately because when things go wrong, there's no way to regulate or remediate. And there's also not, as the next person asked, medical assessment protocols for a lot of underground work. Some do, some underground practitioners absolutely have the highest level of care. But then there's a lot of, like you said, on the completely illegal market where people with no facilitation training, no medical training, no anything are facilitating. And I've seen harms come from that. And yes, so the answer is yes. Self and even not self-medicate. You can go to somebody else and say, facilitate this for me, underground, which is why it's great that countries are trying to bring it above board so that we can have things like our next person asked, medical assessment protocols. So we suggest, instead of just going to, whoever who happens to have some mushrooms, if you have, at all complicated medical history, and by that, I even mean like as much as a first degree relative with bipolar disorder or psychosis, which are some of the things that have been like excluded from trials, you should be going to a medical clearance first. So to answer your question, do we have medical assessment protocols from your association? So the one course that we have put out is called Managing Medical Risk for Patients Undergoing Psilocybin Therapy. Because unlike surgery that has been around for so long, and now anesthesia has these clear guidelines, basically like, okay, does the patient's EKG have this, and their blood pressure is this and this? We think they're pretty well good to undergo surgery. Psychedelics is so new, they haven't studied so many things. So we don't yet know if having history, first degree or self history of a psychotic disorder is a contraindication. All we know so far is what has been studied. So gratefully, like currently, I think UCSF is studying psilocybin in those who have bipolar disorder. So then we will know if it's safe in those. But right now, so many medication interactions have not been tested and that kind of thing. So instead of actually having a clearance where we can like obviously say, yes, you're clear, or no, you're not clear, what we put out based on the available research is a course on how to manage medical risk. And by the way, when you take that course, this is slightly more applicable. Well, actually for you guys, it'd be super applicable because you'll have psilocybin totally legal. When you take that course, if you pass it, you're put in this directory we are developing called the Psilocybin Informed Clinician Directory. Because say you're a patient who wants to undergo psilocybin therapy, you don't currently have a clinician and you want to know where to go so that you'll go to a clinician who does know about psilocybin, that's what our database will help those patients find. So if you take our course, pass it, you're in our association. And the reason we want you to be in our association is because if new things come out about psilocybin, we want to send them to you so you have them. Say we find out the results of the bipolar and it says, oh, bipolar, it's okay for people with bipolar disorder to do psilocybin. Great. We want to send you that update immediately so that you have it. So that, yes, so that's the one thing we have. Ketamine also, ketamine's been around forever. And so that's, those are our more widely known parameters. But a lot of the other psychedelics, we know ibogaine can have prolonged QTC, but so many of the other psychedelics we're still working on what exactly it looks like. All we know is basically what's been excluded from studies so far. But those clinical practice guidelines, they will be upcoming. That is definitely something that needs to happen as part of this integration. Thank you for bringing that up.
It's also really complex, Lynn, that, the different cultural paradigms, because in a lot of ayahuasca cultures, if someone's experiencing symptoms of psychosis or dementia, often different master plants are given with ayahuasca. And, it's the exact opposite to our culture. If someone's destabilized or, losing cognitive faculty, they tend to not give them a psychedelic. And that would be an exclusion in our protocols. But I just want to acknowledge they're the different paradigms, and in our culture, there's no real space to have psychosis. We need to get rid of it really quickly. It doesn't fit with working 9 to 5 and productivity. Whereas in more traditional cultures, there's room and space for someone to have these peak and altered experiences, and it's not as shut down by the culture.
Yeah, I think the next question in the chat is for you, Lani.
Which one is that?
From Karen.
From Karen, sorry. 100 hours of core. Oh, okay. So AMAP doesn't endorse specific training providers. We've decided not to do that at this stage because for a whole range of complexities, there's you know, dodgy providers in Australia. There's emergent providers. It's very complex. So instead of endorsing providers, what we're doing is we've set a roadmap where the individual can, on an individual basis, submit their application to us, and we assess them based on our criteria. So if they can demonstrate that they have done, you know, the core training, supervised dose sessions, a supervisor can sign off for them, all the different checks and balances we've put in place. So it doesn't necessarily matter where they've done their course, as long as the course lines up with our credentialing framework. It would have, and because it's there's preliminary. A lot of people will meet the preliminary phase. They might have done like a CPAT or a, you know, Psychedelics Today course, but to be fully ready, you need to have been supervised and watched, and someone who's you know, AMAP accredited as a supervisor needs to have signed off that you can work in altered states, that they've seen it, that you know, display, you know, wisdom in regards to spiritual and altered state perspectives. So doing a course is not enough to then just be allowed to be, you know, in a room unsupervised. So yeah, lots of steps there. And any other questions, you can email me directly. I'll put my AMAP thing here, because yeah, credentialing is it's complex, doing it on a one-to-one individual basis, but it's actually the best way for us to assess at this stage individual competencies. Okay.
You've got another question about volunteer positions.
Yeah, so we have different steering committees. So we have education team, community outreach, and provider relationships that I'm the board seat of. We have policy, and you know, we've got fundraising, kind of marketing. So if you want to volunteer, it's about, you know, where are your passions, where are your skills, and then we connect you with a team, and on each team there's a board member that feeds back directly to the board. And yeah, it's been pretty phenomenal to see in 5 months the policies that have been created by our community, really, and they're real. Like, you know, what we put in place is you know, I'm just really privileged to see what it's like to establish something from the ground up, and to have, you know, nothing gets approved unless we all kind of, the board agrees, and that kind of structure, which we're really conscious of power and really conscious of systems. And obviously each year the board can steps aside and gets re-voted in by its members. So there's no centralized power, which is really important. So yeah, volunteers and members are leading the organisation, because, you know, that's who votes us in. So yeah, encourage you to reach out.
I have a question if people want to put something in the chat. I'm curious if you could put like what kind of clinician you are, and then if you've had a patient ask about psychedelics, what was something they asked about psychedelics that was either surprising or that you didn't know the answer to, so that we can maybe help answer some questions.
Good one.
Or even topics that you all would like to know more about. You know, I run a global organization. I would love to tailor it. Like tonight, we had our webinar, which was right before this, and it was psychedelics and end of life care, because that was something that so many people wanted to know about. And we are starting an Australian, you know, subgroup of the Psychedelic Medicine Association. So I'd love to know what the Australian side, what kind of concerns and questions you have, so that we can get you all speaking with each other. And, you know, I think Lani is on the more therapist side, which is so important for us to learn from. We have therapists, but like a lot of what we do is focus on the clinician side, obviously, because I think therapists are a lot more already tuned into this, and our, you know, medicine colleagues maybe a little bit more conservative and a little slower to get to it. So we're still working on that front. As a therapist, I've been asked what my stance is by a few clients. Some people are getting more and more curious as a result of documentaries. Ah, interesting. Yeah, and that kind of goes into, it's still not a space many physicians are comfortable with. People are curious about safety. Absolutely, right? Like we've been told for a bajillion years that these drugs are very unsafe. And Also, we've been told that all drugs are addictive, right? So the fact that the majority of psychedelics are not addictive and maybe anti-addictive is a whole new paradigm that that's the thing that I think changes most clinicians' minds, because I think that's what's front of mind is like, especially when we're talking about like, yeah, this person has an opioid addiction, they should do a psychedelic. What? They're just going to switch one for the other. They're going to be addicted to Ibogaine. I don't know if you know Ibogaine. Nobody's going to be addicted to Ibogaine. It's kind of a brutal ceremony. That's not a thing, right? And then such impressive results from Ibogaine. And so I think that's one of the things is when you talk about safety, talk about the fact that most are not addictive. Most have massive like safety profiles, right? Psilocybin is very, very safe. And then, talk about setting and therapeutic setting. And like, if you've heard crazy stories about drug use, it was probably not in a monitored therapeutic session, right? Like most drug use that has gone awry is because there wasn't a safe container for that used to be happening. So that's another thing to consider if people ask you about, are these safe? Yes, when done safely. Let's see here.
I might just jump in there. Sorry, just because a lot of clients will ask you what's your stance, and particularly if you're ARPA registered, a lot of people can be really fearful and of speaking out about your own lived experience. And I guess it's an individual choice. Some therapists will never speak out publicly, psychiatrists, GPs, they'll keep it really private. But I guess for just some tips, as someone who speaks out regularly and across many platforms and has had dealings with ARPA, positive discussions that have helped me really solidify how to do this. It's balancing the lived experience versus the advocacy, because obviously if you're positioned as a leader in the space, clients can be very vulnerable. And if they see you talking about how much you love ayahuasca and how great it was for you, could be a potential power imbalance there. So now I personally, in a lot of my public speaking, say that these are my experiences, and you need to have that calling yourself, and it needs to be unpacked with your practitioner, and just being really aware of the power my voice has, or all of our voices have, to people who are really vulnerable. And obviously not saying if it's because it's illegal, you're not including locations and times and names and places. It's general lived experience. And just keeping, the safety of the community in mind when you do speak. And yeah, I think it's, if someone does ask you your stance, it's just best just to speak from multiplicity and complexity, that it's not black and white. It's very, very nuanced. And what I find now is people listen to harm reduction a lot more if it comes from someone with lived experience who can hold, how phenomenal these medicines are, but also how ready you need to be, because they are very powerful.
And I would also add to that, at least, I know many clinicians in the US are afraid to say that they've done it at all. And there's actually two things to that, because absolutely lived experience, very powerful. But it's interesting that there are certain psychedelic researchers that do not share whether or not they've done psychedelics, because the fear is if you share you've done them, then you may be biased toward them. And so like as a clinician, they may, oh, well, you did it, so that's why you think it's safe, kind of thing. So what I know a lot of people in the US do is, we are allowed to educate, right? And so they say, what's your stance? You can say, well, my stance is that I believe, I practice evidence-based medicine. That's my stance for anything, right? If there's evidence for it and is appropriate for a patient, that's how I make decisions. And there is currently this body of evidence for psychedelics, right? Depends on the condition, right? If they're asking, what's your stance on psilocybin for toenail fungus, right? Well, you shouldn't have one because there's no data, right? But you say, what's your stance on psilocybin for depression? Well, this is what the research says. Still a growing body of research, right? You can just tell that, like in the US, you're totally legally allowed, like, Lani said, from harm reduction and education purposes, you can tell them what data says. What you're not allowed to do is aid and abet, right? And so we can't tell them like, here, this is where I suggest you go do the psilocybin, because we do not have that option in most of our states. But you can tell them, look, I don't need to take a stance. This is just what the evidence says, right? If whether or not you've even had your own personal experience, you can tell them about the evidence. So somebody asked about weaning reds. Absolutely. That makes a lot of sense as a big question. And again, another area that's still trying to be decided. Do SSRIs decrease effectiveness of these other meds? You know, there's seemingly like kind of conflicting information. Somebody said, surprise the client, they're not, who then said they were not? Oh, somebody, by the way, asked me what it's like in the US. Yes, it's actually, I mean, I live in California, which is very hard to judge the rest of the country by. However, my parents live in the absolute middle of the country, like country corn. My dad is, 76 or something, and he went to his prostate doctor who knew about psychedelic medicine. So yes, I think it is getting out there, thankfully. I'm just trying to read some of these.
Just want to add there, just a lot of my clients who aren't ready to come off their medications are working quite successfully with cannabis and ketamine, because you can still experience, altered state, peak experiences with those medicines and still be on a whole range of medications. So just something to keep in mind in the preparation phase. If a client has their heart set on ayahuasca or psilocybin, part of the preparation might be, well, you're not there yet, you're not able to taper off. Is there other altered state work or other medications that are accessible that they can feel what it's like, but still have their medications running through their system? And often that gives them a lot more confidence and they feel more ready. A lot of people taper off antidepressants with cannabis as well, supporting them.
Yeah, very good point. And to whoever's asked about what's the latest research, I would go to spiritpharmacist.com, spiritpharmacist.com. He just keeps up to this 100% of the time. That website would be the one to have the absolute latest. I wish I could keep up with all of the information. Thank goodness we have more other people at the PMA that, put together the research, but still. And Dr. Ben Malcolm, the pharmacist who's behind the Spirit Pharmacist, he's on our board and he writes all of our guides for that kind of thing. So I would check out his website. Let's see here. Yes, Ben is so sharp. He's like, literally, especially if pharmacology is your thing, go check out spiritpharmacist.com. And also, if you join the PMA, we have multiple webinars that he's been on that are all able for you to rewatch. And I think he's addressed that question many times. But as you know, I think the last time he was on was maybe 5 or 6 months ago, and things change very frequently. Like, I think whoever said that, it's not that there's conflicting information, like you've heard one thing and then there's another. Things come out from both sides saying both things. So it is kind of confusing. And that's why, like, if you have one study that says this and one study that says the opposite, and there's only the only 2 studies, it's very confusing. Once we have a pile of data, hopefully there'll be a much larger pile on one than the other, and then we'll have a slightly more definitive answer.
And just to your comment, I'm not sure if I'm saying your name right, Thaisa. Obviously there's a lot of concern in the mental health setting that there's not enough research for the TGA to have made this decision. But, the reality is the decision's been made and we need to move forward with that. But I like to have the discussion that we are very comfortable with the amount of side effects with psychiatric medication. It's a norm. We give out these medications to children, to teenagers. We know there's increased, sometimes suicide thoughts, weight, anxiety. There's a whole range of side effects with these medications, but they're just normal now. So when you're talking to colleagues, someone,
Yeah. Do you hear that?
Yeah, I think it's gone. Someone not on
Everybody.
the windstorm. Joanna, you might have to mute from your end, Lynne, because you're the co-host. Yeah. So it sounds like we were headed for a tornado or something. So yeah, my point being there is you need to really advocate strongly that there are risks in all medicines, and pretty profound risks with some of the psychiatric medicines, but that's normalized and just accepted. So we just need to balance that these are new medicines coming in. We need to be fully aware of the side effects, but the data is looking very strong particularly for psilocybin and MDMA. So just speaking to the data, speaking to the facts and changing, just the amount of side effects that we have to deal with anyway in the current system. This is no different. this is absolutely no different, and we just need to really educate them about that. Any others? We've still got 10 minutes left. Any specific questions about psychedelics or systemic change, or any myths, or anything that you've just wanted to know that we could unpack here?
So can you tell me in just like the I'm sure you probably said this before, but since you have so many terms, like in basic with no terms that only Australians use, how does the system of a patient getting that? You said there are 2 people that are qualified to write the prescription. Those are 2 prescribing doctors, right?
So it will be psychiatrists will be typically the prescribers of the medicine, but medical professionals will be allowed to be in the room, such as GPs, paramedics, nurses, in the triad as well, if we go by our credentialing pathway. Yeah.
And so then does the psychiatrist who prescribed it also have to do this 8 hours of therapy sit with the patient?
No, so we don't think that is sensible. I mean, we would, in an ideal world, that would be fantastic, but not every psychiatrist does an 8-hour course on every single medication that they're prescribing. So it's like, if they want to be a therapist in the room, then they need to demonstrate that they've done additional training to be able to hold that container from prep, dose, and integration. But to be a prescriber, they definitely need to have done professional development, but not like a full CPAT training.
What, and CPAT is?
Or like a certificate in psychedelic therapies. We wouldn't expect psychiatrists to do 6 months or a year-long training if they're just going to prescribe. But if they're going to be a lead in the room, as we know, it really does need, that's the psychotherapy skills container there. Yeah. A lot of psychiatrists don't have psychotherapy skills.
Right. Yeah. Yes. So similar to what MDMA assisted psychotherapy is likely to look like, that we have the prescriber that prescribes it, and then the therapists take over from there.
Yeah. It's really special though when you meet a psychiatrist that does have those skills. It's just being able to balance the medical science with the transpersonal. And there's a few in our community, and a few in PSIP on the teacher trainer path with Saj, and with cannabis and ketamine. And it's very, very special humans when they can work, move all those pieces.
So somebody asked about psychedelics in death and dying, which if you join the PMA, you can just watch the thing we just put on. But there's some of the earliest studies on psilocybin was psilocybin for end-of-life anxiety. And that was shown to be very efficacious. And most people in the study, or a significant amount, ranked it as one of the 5 most significant events in their life. And they significantly had a significant decrease in end-of-life anxiety. There was also demoralization in long-term AIDS patients, which is not exactly end of life, but kind of some similar, I don't want to say terminal illness. Luckily, AIDS is no longer terminal, but people who'd had AIDS for a long period of time, it really helped with demoralization. Other things that they're looking at for end of life is obviously pain, right? A lot of people have end of life pain, and in addition to, the anxiety and distress from end of life. And so one of the things that the hospice and palliative care docs in the presentation we're talking about is just like they've got an ALS patient, and they're going to use some psychedelic therapy with that patient and see, does it help with all of the end of life things, but does it also help with some of the ALS symptoms? We know a lot of these can have multiple effects, especially in the pain world. So yeah, that's why there's a lot of thank you. That's why there's a lot of interest in that. And also I think because this is like Lani was saying, in ayahuasca, dementia and psychosis is not a reason to not do it. But in the US, it's like, at least death and dying, it's like, well, we've tried everything else. There isn't anything that works. And, I think that's why we have kind of right to try laws, and we're allowed to try some more things with that population. And, we're learning from that population. It's it's really promising use of psychedelics for sure.
I also worked with someone who was approaching death and was looking at psilocybin, but decided on breath work because the person had never done any altered state work, and it was too fearful that what if it actually didn't bring him peace, and what if it didn't go well, and maybe breath work was an opportunity to kind of open up and let go. That wasn't, so I guess being mindful of what other altered state work is available for people to try first, it can be really helpful, because we often ignore that there's vision quests, there's breath work, there's drumming, there's even fasting retreats, there's different modalities that people can get in contact with those states and gain confidence. Beautiful. Well, thank you. We made it happen. Only got a couple of minutes left. I really, really appreciate you, Lynne, being here, and Marie, and I hope we can, AMAP can do what we can to support the Australian PMA chapter, or however you like to frame it. We would love to, keep supporting that. There's so much knowledge that we can all share from each other and learn, from our different systems around the world and how to get things done at different stages, and support each other, because it's rapidly growing, but it's actually a pretty small community still, and we need to look after each other. So yes, thank you for being here.
Thank you for having me.
And you can reach out to PMA or AMAP, and always happy to answer any questions. Thanks everyone. Beautiful.
Thank you.
Yay.